Some are just reminders. Safety, we're going to go over safety, patient experience benchmarks, core quality, metric performance, best practice. I don't think we included a future initiatives. So we're going to have a new lead clinical nurse starting on Monday, May the 18th, the Keela Nose 4. She will do many of the things that Stephanie Thornton did before she left last fall. So I think that'll be a great addition to Bartlett. So I will probably have her spend some time with the providers, understanding workflows and how nursing and CMAs can assist and collaborate to provide excellent patient care. Just also, and I see this happening, and I hope that you find it beneficial that we're using secure chat. If CMAs are not visible at the workstation, we are fully staffed with CMAs. And then also just using the CMA secure chat to communicate when you're running behind, or if you want to see patients earlier, where if a patient's not coming and you want to see if they'll switch to telemedicine, you can also secure chat the CMAs about that. And just always, it's important, I think, to do a check-in with them at the beginning of the session for any anticipated patient or clinic needs. Just a friendly reminder to be checking Epic daily for messages and just to be in clinic on time so patients aren't waiting. Any questions, concerns, comments there? If not, I'm moving on. Thank you. We're getting a new FibroScan machine that's being set up on Tuesday, May the 5th, and all the CMAs will be able to perform FibroScans in clinic. I know in the past we only had one or two, but now every CMA will be able to complete FibroScans. Something that's been happening, and I think most providers do it, but just a friendly reminder to escort patients to check out. I know you can't stand there with them to make sure that they are actually talking to one of the PSCs, but just saying to them it's really important because your next appointment will be scheduled and any referrals can be scheduled then.
I'm
D
sorry,
is
Sheila, you're asking this for everybody or just for the fibro scans?
no for everyone. I thought providers always
Hmm.
escorted people to check out.
I mean, I show them where it's located and where to sit for checkout, but I don't.
Well, I mean that.
Oh, okay. So they know
Yeah.
where to go and
And
sit.
just
Okay.
telling them the importance of stopping at checkout for
Okay.
your next appointment, for any referrals, like I've put referrals in. And the
Okay.
way to have that happen is to stop at checkout.
Okay.
And
Thank you.
Sheila, just a quick question on that. I know there's that like order, like follow up with me. I never use that. I always write in the little notes in the visit thing and say, please schedule on this date with me or in 3 months or in 6 months. And then I put in there if there's anything that I want them to schedule at checkout. That it seems effective for the schedule with me. So I think they look at that, right?
They do.
Okay.
I
They
believe
do,
that.
but the order is something
I
that the
know the order is a
members that
metric.
see, yes,
And
would
I always do bad on that metric, but it feels like an
redundant.
extra and also like it's not only with me. I want to write the note about like when you're coming with
A
me.
100%. A
Yes.
100%.
So I think I'll just
Good.
continue to do bad on that metric if that's okay.
Okay. I will let you know.
I
And
don't think that's is that a metric that you're supposed to be doing
oh
fibers
yeah.
with me? Okay, maybe
Oh
that's
yeah.
one that I'm not aware of. Oh, okay.
Mhm.
Good to know. And then, D, I think you guys all know this, is very available for questions about annual wellness visit documentation and billing coding. Because oftentimes, what she does look at every month, she'll be like, oh, we did the annual wellness visit, but the coding isn't correctly. And then she'll come reach out to you if there's things that need to be rectified with the coding. Um, and then secure chat the nurses for questions, assistance, collaboration with patients who are here for acute visits. I know with the new overbooking, it's especially important to understand what the person is coming in for. And I am meeting with the nurses next week to really kind of flush out that workflow so that nurses are doing a triage note that assists you with the assessment and then also assessing the patient when they come in. So just any ideas that you have, please let me know, but we are trying to make that more seamless, good best practice for our folks who come in with acute issues. So we're working on that. Please let CMAs know if you're changing an in-person visit. I talked about this to a telemedicine visit and if telerooming is needed. Some providers will just be like, I'll call them, but if you want them to teleroom, please let them know that. Questions there? Okay. So
Is
now we're going
that
to look
is
at
that not, I'm sorry, is that not an automatic process that they do rooming? That the CMA,
if they don't know that somebody's changed to
oh, if it's
telemedicine.
changed, if it's known to be telemedicine, then
If it's known to be telemedicine, they do it. There are providers that don't expect telerooming.
okay.
So, and the CMAs know who they are.
Okay.
Um, here is our patient experience and safety scores from March of 2026. Um, anything in green, purple, blue, we're doing an amazing job. The green is 50th to 75th percentile, the purple is 75th to 90th, and the blue is greater than 90. So really great stuff there for hand hygiene, provider communication, overall provider rating. So thank you so much. The red are areas that we need to work on. The visit wait time dropped a bit, as did the overall provider visit rating, overall visit rating. Patient ID, I like we're really close at 89%. And then staff worked well together, a little bit below that at the 82nd percent. So a little bit of work to do, but my gosh, overall, look at that. I think those are amazing numbers. So be proud of that. And then these are our quality, safety, and service metrics that we look at. And this is for the month of March. So for OB, we're great about chaperone. For non-OB, we're at 85%. So it's just, I will speak with the MAs again, but the importance of asking someone if they want to chaperone, and then if they do want to chaperone for a sensitive exam, making sure that it's documented that a chaperone was used and the person who did the chaperoning. So we need to get back to 90% on that. Closing encounters within 7 days, very close. Fall risk screening, that's a drop, and I'm gonna talk to the MAs about that. We were doing really well in that, so I'm a little concerned that somebody's not asking that question, and I just need to do some education. But look at the rest of them: hand hygiene, hero documentation, in basket messages read in 2 days, interpreter services documented, patient ID, and test follow-up. These were all great. So thank you all for that.
Sheila, Chloe just put a question in the chat about if you could just go over what patient ID means. Like
So
that metric on the last slide that you said was a little
if
on.
we ask the patient their name and date of birth.
And how is that actually? So the patient reports that?
So with the MAs ask that,
I
can you
know,
give
but
me your
how is the
name and date
metric
of birth?
generated?
So there's a questionnaire that goes out to patients after the
Okay.
visit.
Okay.
And they ask, did somebody ask you about your identity? I
Okay.
forget the wording of it, but we're doing it. Woohoo. So I mean, it's so funny when I meet with patients and I've known them for years. You've known these people for years. You still should ask name and date of birth. People are really like, you know who I am. Well, I have to do it for safety reasons. So here's our primary care quality metrics. This is again, these are all for the month of March. So we're getting there. Breast cancer screening, colorectal screening, we are within 5% of that. The depression screening, again, I feel like I need to do some education with the MAs on that because I know that they do that. Um, the diabetic hemoglobin A1C always starts out low in the year. So, I mean, our number was even higher in January and February, but as the year goes on, I'm sure we'll meet that. The lower number is better. Diabetic kidney health evaluation, we are within 5% of that. We are meeting the diabetic statin therapy metric. Hypertension, we're within 5% of that. It's like 3%. Statin therapy in patients with cardiovascular disease, really close there. And the annual wellness visit, still a work in progress. But I have a a slide coming up to show you how far we've come. So a little bit of coming attractions on the next slides. Um, and then we talked about this already about the HCAP scores, so I'm not going to review them again. And then this is our value primary care only, our transitional care management, and our utilization. Hospital discharge calls within 2 days, 77%, hospital follow-up within 77 days at 33, hospital follow-up within 14 days, 52%, ED discharges contacted within 7 days or at 85%. And then our utilization, still some work to be done. We hired a new nurse that replaced Fatima back in March. I'm pretty sure that Cherie Bevan started then. And I'm giving her until July to get really up and running and understand this whole process. And then my hope is, and she knows this, the not hope, expectation is for her to really kind of dig into these people who are being readmitted into the ER in the hospital and see how we can move the bar on these readmission rates and what she can do to work with those people that are high utilizers of hospitalization and ED. Questions, concerns, comments for any of these metrics? So this is just another way to look at how we've done compared from last year to this year on our metrics, where we are in March and where we finished the year last year. So again, we're already above in colorectal cancer screening. And here's the other thing, the denominators change. But good news is, look, we're already ahead of what we were last year. So the diabetic, we're already, well, lower is better. Yep, we're already ahead of where we were last year. We're already ahead in the diabetic kidney health evaluation, so that's great. So the statin therapy, we're already ahead there. Controlling hypertension, we're almost where we were last year, and it's only March. We're already ahead in the statin therapy, and the annual wellness visits were ahead of where we finished up last year. So overall, really good news. We're progressing in the right way. And then I just think these are great to look at. This is where we started in 2020 with the breast cancer screening. This is breast cancer screening. So in 2020, we did 47%. And in 2025, we were up to 83%. So look at that trend. It's amazing, right? We doubled the amount of breast cancer screening in the last 5 years. So great work, everybody. I always just think a slide like this, I hope that it motivates you to be like, yeah, we got this, and all the hard work that everybody's been doing towards this. So this is breast cancer screening. And then here is colorectal cancer screening. In 2020, we were at 60%. And again, in 2025, we're at 82%. So again, just over the years, you just see we just keep climbing. So thank you, thank you, thank you. I say to Jen, the nurse that works on that, one colon cancer screening at a time. And to Dee, when we get one Cologuard done at a time. So we're making progress. And then the next one is our primary care metrics. No, I'm sorry, is our diabetes, hemoglobin A1C. Back in 2020, we were at a 30% rate. And then look, we finished 2025 at 8, which is again beautiful. That's what it wants to do because the lower number is the number that we want to be at. So just amazing progress there. Is D on? I don't know. She's probably still giving the Cabanuva. And then this is our annual wellness visits. You on, D?
Yeah, I'm here.
Okay, I'm going to let you do the next few slides. I'll do this one. So this one is our annual wellness visits. So back in 2020, we did 34%. And look at us, like we're getting there, we are at 73%. Again, doubled. And in 2024, we were at 80%. So, we have just made these amazing strides in all these primary care metrics. So I just want to thank everybody again. So Dee, you want to do this slide?
Sure. My Cabanuva is here now, but
Oh,
it's
okay.
up
No,
to
then
you. You can go ahead and continue on.
okay. All right. Thank you. So Dee just does such hard work with all of these metrics. I just want to applaud her for all the work that she does. So this is our non-OBGYN target of we're supposed to be at 90%. And in March, as of April the 27th, so just 2 days ago, we were at 81.79%. So sometimes the CMAs, I mean, most of the time they ruin people. So we got a little bit of work to do in that. So we do have to really ask that question about if you have a sensitive exam, do you want to have a chaperone? And then that once they are present, and the name was provided, we were at 74%. So again, we need to make sure we're putting our names in if we chaperone. And then this is our interpreter. So for anybody who doesn't have English as their primary language, we are supposed to be getting an interpreter for them. And again, it's very important that we document either the number or the name of the interpreter in the note. So this is through April the 24th. And Bartlett is at 75%, and we're looking for a target of 80%. So if you use an interpreter, please make sure that you're documenting the interpreter that you're using. And then here's the documentation of how you use the interpreter services. So this is the way you go right under here under rooming, communication interpreter, services used, the interpreter full name or ID number. And you can also use this smart phrase if you'd like to do it that way. And then to identify if somebody has English, a language other than English, it's over in the storyboard. If they say, my language can be updated, I really do prefer English, then you can update that. So that goes over here to how to do that. All patients with the preferred language other than English, as we said, must have a interpreter. So then continued best practices are that RN outreach efforts continued. If there are people that you want outreached on the RNs days at home, please let the RNs know that, but they are reaching out to people for hypertension follow-up, colorectal cancer screening, breast cancer screening, diabetes. So all the things that that we're looking at, and then anything else that you would like us to look at. Continue to have your care team meetings because that's really important. Same day workflows, again, if you would like somebody to have a mammogram, the diabetic retinopathy screening is a little bit, harder to do because there's, certain time frames, but Dee really is able to take people over for the mammograms and diabetic retinopathy if we can get it done on the same day. And then anybody that has a blood pressure greater than 140/90, please make sure they have a follow-up within 6 weeks. The CMAs can do the Omron and then see if they have follow-up visits with their RN, the PharmD for medication management and just education. Questions? And then the annual
I have a
wellness
quick
visit.
question, Sheila. Sorry, this is Willa.
Sure.
That
Yeah,
BP of 140/90, is that just if they're getting primary care at Bartlett?
primary care. I mean, we could still do the Omron. But it really should come from their primary care provider to be doing that follow-up. And then the annual wellness visits continue delivering exceptional care by completing these. If you can't do it the day of, I understand if a patient comes in and there's too much else going on with them, just schedule for an annual checkup and the wrap up to ensure that rescheduling can be done. And then PSCs are scheduling annual wellness exams 1 year out. And if it's not done at the time of visit, let that, indicate that in your visit note because this helps with reconciliation and chart audit and just make sure that you're like, yeah, schedule them the next time. And then the colorectal cancer screening, we can utilize the navigators to escort patients. You can refer patients to their nurses for bowel prep education. We have the clear liquids in the clinics for patients who need them. We have 2 Cologuard kits in the clinic, and Dee's willing to educate patients about the demo kits. We also, Jen made a really nice one-pager on when you get your Cologuard, this is what you need to do. Because the instructions they're not hard, but she even made it a little bit easier for patients to understand what they need to do with their Cologuard and is willing to have patients, talk to them, and whatever we need to do to get it done, one at a time. And that's all that I have. Any questions? Look at me, 3 minutes over, even with the debacle of not being able to get it started.
Well,
Thank
thank you, Sheila, for all of those updates and for everything you're doing to keep us doing as much as we can for our patients.
We're doing a great job. You saw all those graphs. We're going up, going up. So thank you all. Have a great weekend.
Great. Thank you, Sheila. And I will get us back to our case for the day.